Morning to everybody, or should I say good evening to everybody. Thanks for joining this very exciting session, which is focusing on complex percutaneous coronary intervention, focusing on calcified lesion, long lesion, and instant restenosis treatment. For this first session, we have a very distinguished panel with Dr. Jung-Min, Dr. Kefei, Dr. James Flaherty, Dr. Nakamura, and Dr. Scheller. So without further ado, let's introduce the first speaker, which is Dr. Mamas from Keele University, United Kingdom. The title of his presentation is "What is complex PCI? Do outcomes depend on complexity, type, and number?"
So thank you, Dr. Palmerini. It's a great pleasure to join colleagues today in this very important session. So these are my conflicts of interest. My name is Mamas. I'm Professor of Cardiology based at Keele University in the United Kingdom. So defining complex PCI is complex in itself. It's similar to defining what a duck-billed platypus is. Everybody knows exactly what it is when you see it for the first time, but trying to describe it to somebody else is often very challenging. So you may say, well, it looks a bit like an otter, it has a bill, it has flippers, it has a tail, it lays eggs. And similarly, complex PCI can be described in many different ways to many different people. We all know what it looks like, describing it is a different matter. And we can describe it in many ways. So this is one way of describing complex PCI, and that's through both the severity and the extent of disease using the syntax score. And so whilst at the individual lesion level, there may be lesions within a coronary tree that are relatively simple, overall the burden is such that it makes the case complex. We can further refine what complex PCI is by thinking around different aspects of the case. So we can think about the anatomy. So for example, whether the case has multivessel coronary artery disease, calcific lesions, left main, bifurcation. We can think about patient comorbidities. So for example, whether they have a history of cancer or diabetic or have significant renal impairment. And we can also think around the sorts of equipment that we may have to use. So for example, mechanical circulatory support, atherectomy, and so forth. And taken together, this may define what complex PCI is. We can further refine it by introducing the concept of chip. So one of our next speakers, Dr. Kirtane, produced this white paper, or led to the production of this white paper, where again we sort of think about individual components of a case, so focused around patient comorbidities, complex coronary artery disease, and hemodynamic compromise. And when these aspects intersect, they produce what is termed as a complex, higher risk and indicated PCI. We can also think around what we mean by complex PCI by considering individual lesion characteristics. And in fact, this is what the ESC considered in their definition of complex PCI in their DAPT guidelines. And so they defined complex PCI as 3-vessel disease, at least 3 or more stents implanted, 3 lesions treated, bifurcation lesions, particularly with those requiring 2 stents, long stents, which was defined as a total stent length greater than 60 millimeters, and chronic total occlusion. And later iterations of these lesion definitions have included cases with heavy calcification that have required rotor ablation, or unprotected left main disease, or saphenous vein graft PCI. And when we think about complex PCI, how common do we encounter it? I mean, if you go to a room and ask everybody in the room, you know, how many of you do complex PCI? You have the whole room's hands shoot up, and everybody says they do complex PCI. But if we look at this more dispassionately, we find that around 30%, or around 1 in 3 of every PCI is undertaken for elective indications are complex, according to our analysis in the UK British Interventional Society dataset. So even though now we've discussed what complex PCI, and you can see that complex PCI can mean many different things to many different people, there is limited data on really whether the outcomes of complex PCI depend on, number one, the nature of the complexity, and number two, the number of complex lesions, particularly when thinking around single platforms, because obviously these sorts of analyses can become confounded when multiple platforms are used, so by indication, a bias. And so we looked at this question specifically using the eUltimaster registry, which is an international registry from over 150 centres across the world. And this included 38,000 or 35,000 patients with 95% follow-up at 1 year. The primary endpoint was target lesion failure, but we looked at a number of secondary endpoints, including cardiac death, target vessel-related myocardial infarction, and clinically driven target lesion revascularization. And we defined complex PCI as per ESC criteria, basically defined on the basis of lesion characteristics rather than clinical characteristics. And we included factors such as multivessel PCI, more than 3 stents implanted, more than 3 lesions treated, bifurcation PCI with 2 or more stents, total stent length greater than 60 millimeters, and chronic total occlusions. And these were PCIs undertaken with a single platform, the Ultimaster drug-eluting stent platform, which is a cobalt chromium 80 micron thick platform with an open cell design and a bioresorbable polymer that was a abluminal coating. And you can see that, again, in this population, around 1/3 of all PCI cases are complex. About 2/3 of those complex cases have 1 or 2 complex lesion features, and around 1/3 of them have 3 to 6 complex features. And the most common form of complex lesion is that of multivessel treatment. And these are some of the data. So this is just stratified according to the presence or absence of complex PCI, and consistent with many other publications in this space. Complex PCI is associated with worse ischemic outcomes, for example, target lesion failure, stent thrombosis, target vessel MI, but also, interestingly, major bleeding complications as well. When we look at outcomes according to whether it's target lesion failure, cardiac death, target vessel MI, or stent thrombosis, you can see that the prognostic impact of the individual types of complex lesions is very different. So you can see that certainly for some of the endpoints, bifurcation disease with 2 or more lesions has much worse outcomes, whereas something like CTO, once you've adjusted for differences in baseline covariance, isn't associated with adverse outcomes, with the exception of perhaps stent thrombosis. So certainly we do see very different prognostic impact of different types of complex lesions once you've adjusted for clinical characteristics. We also see very different outcomes as per number of complex lesions. And you can see for all the endpoints that we looked at, whether it be target lesion failure, cardiac death, target vessel MI, or clinically driven target lesion revascularization, you have almost a dose response curve in that the outcomes progressively become worse as you go from non-complex PCI to PCIs undertaken with 1 to 2 complex lesions to those undertaken with 3 to 6 complex features, as you can see. And this is consistent for all endpoints. And so really the take-home message from this presentation is twofold. I think first and foremost, complex PCI can be defined in many ways. And I think we're yet as a community to decide and to agree on what we mean by complex PCI. We all know what a complex PCI looks like when we see it. Defining it is very much a different problem. And it may relate to procedural risk and future risk of ischemic events. And we often think of complex PCI around the distribution and extent of the disease, the characteristics of the lesions, important patient comorbidities. And so you may have a complex PCI of a type A lesion in a patient that's multimorbid, and patient hemodynamics. And I think when thinking about complex PCI, we have to think about it at the lesion type, but also at the number of complex features that are involved in the case, and very much plan our antiplatelet therapy and antithrombotic therapy based on this. So I'd like to thank you and pass over back to the chairperson.
Thank you very much, Dr. Mamas, for this really excellent presentation. So let's move to the next speaker, who is my friend, Dr. Jay Kirtani from Columbia University Medical Center. The title of his presentation is My Worst Heavily Calcified Complex Case, Expert Tips for Guiding Wire, Catheter, and Special Balloon. Ajay?
Thanks so much to the chairs and also to the organizers of the meeting. It's a real pleasure to be here. Unfortunately, I can't be there in person, but this will have to suffice. I actually took this title to heart, and by worst, I can show you in some ways worse things that can happen during the case, and hopefully we can get some pointers along the way. I really liked the prior talk by Mamas, and it shows you that many times actually in this case, for instance, we can see a case where it doesn't appear to be too complex, but we can make it complex, and that's another aspect of this that needs to be addressed. So this is a patient who had a prior PCI to the RCA, had typical risk factors and a newly depressed ejection fraction to 30%. It had previously been 50%. Here are the diagnostic coronary angiograms, and I think one can appreciate in the right coronary, there's not only calcium, but there's also an underexpanded stent in this mid-vessel right here. You can see it in two views, and one of the interesting facets about this is that we see an hourglass, but it's not a typical hourglass where it's super tight in the mid-segment, and that's important, especially here in the United States, where at the time of this case, we didn't have certain options that might be very beneficial in a case like this. Here is disease on the left side. The circumflex is large and generally okay. And there's calcific disease of the LAD, both in this proximal segment and then a more severe stenosis in the mid segment here. So we aimed to treat this, and we actually did a right heart catheterization because his EF had newly dropped. His wedge was elevated, his PA pressures were elevated as well. I can wager that most people around the world would do this case without hemodynamic support. One of the challenges, at least in the United States at the time this case was done, though, is that especially for an underexpanded stent in the right, we had limited options in terms of what to use. We thought we'd have to use contrast laser or otherwise, and so we actually elected to put in hemodynamic support for this case. Now, I'm not going to show you what happened with the right coronary other than to say that it was difficult to dilate this. We had to use serial NC balloons to very, very high pressure to then be able to crack this calcium behind the stent and then put the stent successfully in the right coronary artery. This is what the final result looked like. And that's again, because we don't have lithotripsy here in the United States. We did not have to use contrast laser. The patient tolerated it hemodynamically well, but it was quite a bit of a struggle with numerous balloons used ultimately to affect a fracture behind the stent in a good luminal area by IVUS. So now let's go to the LAD, which is the focus of this talk. And the question is, what tips and tricks can you learn from this? Well, in this specific case, as many of our cases, we generally feel pretty comfortable using a radial approach. We typically feel comfortable using 6 French type approaches, and we aimed for atherectomy. And the reason for that was because we saw what had happened on the right coronary previously with an underexpanded stent, and we said, we're not going to make that mistake again, so we're going to use atherectomy for a case like this to get a better result. This is a type of lesion that looks pretty severe, but actually can be crossed with several atherectomy devices, and we elected to use CSI atherectomy in this case. The guide is supportive. That's a good thing. You want to typically use a floppy wire to do atherectomy in these cases so as to minimize the effect of wire bias. And this was CSI atherectomy at low speed. One of the advantages of this device specifically is you can spin through this proximal area without actually treating it. My feeling was that this area here might not need to be stented because the lumen was relatively large, and that we used the glide assist feature to get to this midpoint and then do atherectomy beyond that. Now, what we tend to do then is we tend to exchange our wire for a more supportive wire. In this case, I elected not to use a more supportive wire because I didn't think that there would be an issue with stent delivery. I think in retrospect, that's something that you can think about, and exchanging via a microcatheter is a very reasonable approach. We want to protect the diagonal branch. And a key facet after atherectomy is you need to dilate with NC balloons to effect a crack or a fracture in the calcific plane so as to be able to deliver and then more importantly expand your stent. So one of the things that people often think of is atherectomy can facilitate stent delivery, and yes, while that's true, you really want the atherectomy to be able to expand your stent after you put it in, and that will become relevant in this case. The NC balloon, as typical after atherectomy, goes up quite well, and we often follow this with an IVUS run. And I'll sort of skip to the key features of the run, where basically you can measure a distal vessel size. Here's some plaque that's not so severely calcified. And then as we come back more proximally, I think what you'll appreciate nicely is there's a fracture plane that one can appreciate typically around this area right here. There's a fracture, which is a good sign and suggests that our stent is going to expand. So the area that we treated, now here's the diagonal coming in, had good expansion or good cracking. We're going to expand well, a big lumen here to land our stent. And then I want to key you to the more proximal area. And this is one of the tips I'll use, is that when you do intravascular ultrasound, you should pay attention to the entire run to then determine how to best to treat. And you can see there's concentric calcification here and a lesion, and that's that proximal lesion we didn't treat. We actually measured the area and it was like 4.5. So the thought was we would elect to leave that alone. And this is where something is going to come back to bite us. So in this case, we put a single drug-eluting stent distal to that zone here. Stent actually was deployed fine and post-dilated to 375 using intravascular imaging. And one can appreciate the stent is very well expanded. Because of these fracture zones, there's actually good expansion throughout. The areas are good. And what I will do is point you, though, to this proximal area that was not stented. So here's the landing zone. This all looks fine. And that other calcific area, there's actually a hint of something here, but the area appears pretty good. And as measured here, this was fine as well. So elected to leave it alone and felt like I had a good atherectomy result. There was this lesion here. Was it hemodynamically significant? Probably not, given the large area, and felt confident about this until when we looked at this picture, didn't feel so confident anymore. And the reason is there's actually a dissection at the superior surface of this here. I'll take you back 2 shots to this IVUS run. And what one can appreciate on the IVUS is exactly at that segment, there's a flap right here that's kind of waving back and forth within the vessel itself. So this is where some of the challenges of calcium become, and that is that we have a large vessel with calcium well beyond the reach of a traditional atherectomy device. It's sort of on the wall, and yet there's this area of dissection, which in a newly depressed EF patient with a fresh stent in the LAD, one could argue should not be left alone. And this is where we start running into trouble. Because basically with NC balloons, I felt I couldn't leave this alone. This simply won't expand. And this is a 408 balloon. We took other balloons and it simply would not expand any further. Now I have a fresh stent distal to this. So to atherectomize this area through an area of bias might be a challenge. I could laser it, but the challenge with laser in this particular situation is this is an unstented area. And so now we have to decide what to do. And as I said, in the US, we didn't have shockwave at this time. So taking specialty balloons, things like Wolverines, angiosculpts, and the like, can sometimes help. And in this case, it looks like it kind of expands. And the MLA after doing this is 5.5 millimeters squared, although we still felt that it was not fully cracked. So the idea here is now we have to stabilize a dissection. And I, again, think it'd be an ideal case for lithotripsy, but we didn't have it. So my thought was, is that at least I can stabilize the dissection with a stent. It won't further extend. The MLA of 5.5, or even if it dropped to 5 would be sufficient, and that would work. And so put a 4.0 stent in. There's a little bit of a waste, but one can appreciate the area is somewhat okay. Post-dilate it with a 4.5 stent. And the question is, was that a good idea? Well, I went back to IVUS it to see what could happen. And then the IVUS catheter basically gets entrapped in the stent. And one can appreciate right here, there's longitudinal compression of the stent itself. So what I've done now is taken a vessel that was otherwise, treated nicely, atherectomized, NC balloon, stented, and now I have completely shot my plan and landed in the exact same situation as the prior operator with an underexpanded stent in this proximal LAD, but now with a stuck catheter in between. So at this point, you have to know tricks. You have to understand what's going on. And so what do? Well, one thing you don't want to do is pull on the IVUS catheter too hard, because you'll stretch this whole thing out and you may even leave it forever. So what I did is I cut the IVUS catheter I put a guide extension down and tried to see if I could get this free. Still would not be free, and you have to be very careful so as to not compress this stent further when this is being done. Interestingly, the IVUS could be advanced, the wire was free, but it could not be pulled back. And so the logic there is that there's probably a severe bend with a spicule of stent that's sort of unroofed, and that's what's catching this at this time. So with that in mind, my feeling was if I could get a balloon alongside it, I could free it up. So I wired alongside it through this guide. But unfortunately, with a 6 French guide and a 5 French IVUS system, no other balloon will fit alongside this. It simply would not get out of the guide. Certainly wouldn't go through the guide extension, but it wouldn't even get out of the guide. So the question is, now what do you do? Well, the only thing to do is you have to free this somehow. And so got contralateral access with a second guide, and then ultimately took a wire, was able to wire into the proximal portion of the stent. The only reason I could do this is because once it was stuck, made sure so as to not have things get sucked in too hard and concertina the stent further, and ultimately got a wire down beyond it, was able to exchange for a more supportive wire, also a wire, the wiggle wire that will get you off these spicules of stents and or calcium, then dilate it further. And with that in mind, with a guide extension pulled forward, the IVUS ultimately came free and was extracted from the vessel. So now that that's done, I still have a problem with an underexpanded stent now that's concertinaed as well in that segment. This is the reason why I called it my worst case, because it doesn't mean that the vessel was that bad to start off with. It was what I did made the case worse. So, but ultimately was able to dilate this up with 4O as well, still with the waist. And finally, thankfully, with a 4.5 by very short NC balloon. And the length is important. If you take a short balloon, you use Laplace's law to your advantage. In addition, if you keep it up for a long period of time, it can ultimately crack, and that's what happened. So 4.5 by 8 cracked, and then this was the result after it cracked with expansion of that area. The question I'll ask is, we'll say, would you repeat IVUS? I know Antonio would. I was afraid to do it, and I didn't want to do it anymore, so we left it like this. With a good result at the end. So what I would have done differently, and why did I present this case? I think number one, you have to recognize severe calcium when you see it. And when you recognize it, you have to image the entire vessel to understand where it is and how it can affect you in a variety of ways. This issue of large vessel calcific disease is an important one to emphasize. We often think of severely calcified, very stenotic lesions, very good cases for atherectomy. But if you have large vessel calcific disease, the atherectomy devices won't often reach the outer rim unless you take a very large burr. So you have to be prepared for that when you go in, or else use lithotripsy. I would say I probably should have used 7 French access. It would allow me to extricate the IVUS catheter easier, and I had a support device in anyway, and I was using single access for it. I would say that I should have done high-speed atherectomy. I already had the device out. This idea to just leave that proximal lesion alone and just treat the mid lesion alone, in retrospect, was a mistake. I should have just done the complete work, atherectomized the whole thing. And I suspect, actually, because of wire bias, this might actually have reached the outer rim of that large vessel and cracked it so as to affect a good result when I put the stent in. I think I should have been more careful with the imaging insertion and withdrawal. We often hear that for calcific and complex disease, imaging is the way to go, and that's true, but you have to be careful in terms of how you do it. And at the end, I would say I just should have had better overall focus, recognizing what happened with the right, didn't want to revisit that on the left, ended up in a bad situation, but fortunately able to get out of it. Hope this case was educational, and definitely looking forward to the next talks and discussion. Thanks so much.
Thank you, Ajay. Very, very nice case. So let's move to the next speaker, who is Dr. Kevin Croche from Brigham Women's Hospital, United States. The title of his presentation is Orbital or Laser Atherectomy in Complex PCI.
Thanks very much to the organizers. That was a great case, Ajay. Thanks for sharing it. I'm going to talk over the next 10 minutes about orbital and laser atherectomy in complex PCI. These are my disclosures. Calcium is certainly under-recognized by angiography, and we know that it definitely dramatically worsens PCI outcomes. Mamas actually had a very nice intro which demonstrated the effect of things like calcium on complex PCI durability. But despite the increasing complexity of PCI, we really see that, at least in the United States, and I think this probably applies globally, the use of atherectomy is quite low. And in the US, 34% of hospitals actually don't use atherectomy at all. And we see in many studies that even in severely calcified lesions, the use of atherectomy is only 35%. And I think that's why many of us are seeing a rash of underexpanded stents, much like the beautiful case that Ajay showed a little while ago with the right coronary artery. And we have a pretty busy referral for stent failure in our center. And we really are seeing a large number of patients who suffer from stent underexpansion, probably because of underutilization of imaging, under recognition of calcium, and underutilization of atherectomy. So with that in mind, I really think the new paradigm is a contemporary image-guided approach to PCI, where we use the imaging to guide how to do atherectomy, what devices to use. And as Ajay showed, actually, when we're done with the vessel prep, when we see fractures of calcium, either on OCT or IVUS, it's then time to stent. And I think this outline really shows quite nicely for either superficial or nodular calcium based on whether devices, the lesion is device crossable or uncrossable with a balloon. Orbital, lithotripsy, or rotational are certainly our mainstays of how to treat complex calcium. And so we really know that imaging guides the decision for atherectomy. This is a lovely study from the CRF group, which correlates the amount of calcium, either thickness, length, or arc of calcium with stent expansion. This is a cool paper because it starts to inform what becomes an atherectomy lesion. If we get to the point where there's a 4-point score here, we know that our stent expansion is going to be very poor without advanced vessel prep. And so this is nice because it can start to bring a vocabulary or consistency to what constitutes an atherectomy lesion in the current era. So thinking about orbital atherectomy, Ajay introduced this already, but orbital is a technology which has an offset mass of a crown that obviously orbits in a 360-degree manner, different from roto, which actually tracks over the wire along a wire bias way. And with the new Viper wire that's available with the orbital device, we actually have less trouble with pleating than we used to with the older generation of the wire here. And so we've actually taken to using this device a lot in the US, especially in large vessels, much like the case that was shown previously. When you think about the different mechanism of action of orbital versus rotational, many of us that use intravascular imaging to support our cases will see this on a routine basis. With orbital atherectomy, you tend to get a different feature of how plaque is modified versus roto, which tends to track along the wire in a longitudinal way. And so we tend to think about this mechanism of action when we're considering which device for which lesion, which is part of a longer conversation we may have time to talk about in the discussion later today. So I'll just show an example of an image-guided orbital case. This is really using the imaging to decide what to do and how to stent, using an OCT approach to workflow. This is a 68-year-old gentleman with end-stage renal disease on renal replacement therapy who had chest pain and a positive stress test. His RCA had no obstructive disease. You can see there's a fairly simple calcified lesion in the proximal LED, and we used our imaging effectively with a OCT-guided workflow to assess the morphology, determine the length of the stent, and determine the diameter in a very rational way. This is not hard. With a little bit of practice, you can employ this workflow either with OCT or with IVUS in a very prescriptive way. You can see that the lesion is severely calcified. The CVI score here is 4. So without question, this becomes an atherectomy lesion. With an MLD max guided plan, we plan to do orbital atherectomy, put in a 4033 stent based on the imaging and post-dilate appropriately based on what we measured. 8 Rens of orbital, 3 on high speed because this is a large vessel. We did 4 millimeter predilation using an OCT-defined 1-to-1 size balloon, and after the stent was placed, we post-dilated aggressively. Initially, our stent was a little bit suboptimally expanded. You can see here in the middle, it's only 73%. So again, based on the imaging, the vessel grew a little bit after we opened it. We ended up doing a 508 just in this area using the co-registered OCT and eventually achieved greater than 80% expansion. And so it's not a particularly complicated orbital case, but I wanted to sort of go through the algorithm of how we use imaging in the current era to be able to do this in a very rational way. So with that in mind, this is the final example of how the case turned out. So thinking about laser atherectomy, this is a little bit more of a complicated discussion because there's lots of things for which laser is indicated. It's typically not a go-to device for severe calcium. It comes in 4 different sizes. The fiber sizes are here, and you have to choose guiding catheters appropriately. You know, unlike CSI and roto, laser's sweet spot is not for treating severe calcium. So in our practice, as we've seen a large amount of the percentage of growth of atherectomy, with all of our cases last year at least being about 20%, we use about half laser and half the mechanical devices, mostly because we're treating a lot of in-stent restenosis patients. Our main use of laser actually is for ISR. We also use it frequently when we have a wire across and gear won't go. or for tissue ablation, and sometimes for CTOs when we have impenetrable proximal caps. These are the percentages here, and the percentages of use are really a function of the fact that we end up treating a lot of ISR patients where we find tremendous value. The mechanisms of action of laser, really the two ones that we use are the light pulse is able to ablate tissue and vaporize it effectively. And then the cavitation bubble effectively works like light-based lithotripsy. Shown in this slide, every time the laser fires, you get this acoustomechanical shock wave. And so this is one of the mechanisms which is actually able to change the compliance of tissue and help to soften material to help you to expand it better. And this shows the laser ablating tissue in an out-of-body model. So with that in mind, effectively, we know from many studies that the laser facilitates stent expansion, especially when stents are underexpanded. If you laser on saline versus laser on contrast, by OCT, you can see more calcium fracture, greater amounts of it in areas where stents are constrained by calcium. This is a case of acute stent regret that I personally did, about 1.5 millimeters of calcium circumferential. Someone unfortunately put a stent into it, which did not expand at all. After laser on contrast and high pressure balloon inflation, you can see the stent expands and we get good fracture seen here in the imaging. So with that in mind, using a very prescriptive image-guided approach to stent failure, we're able to use laser to take patients that have unexpandable lesions and they get them to expand rather markedly. And so using this algorithm works in practice for patients that have multi-layer in-stent restenosis where it won't expand the balloon. So here's a couple examples. Laser atherectomy of 3 layers of in-stent restenosis. The OCT shows, unfortunately, people had kept implanting one stent after another in an unexpandable lesion. You can see it by the OCT. You can even see it fluoroscopically here. Laser on contrast was eventually done. We saw balloons would inflate, not surprisingly. 1/4 laser on contrast at maximum rate and power, trying to harness that acoustomechanical effect. You can see that the stents finally expand well. We don't have drug-coated balloons, so we use brachytherapy in this case. Angiographically expands excellent, and the OCT looks good too. The other place where we actually have value for lasers when we get a wire across, this is a radial case done with a 7 French guide. Relatively straightforward CTO. The RCA was long-standing and was not the focus of this case. We got across relatively easily with a Pilot 200, and we actually could not get any gear across. Turnpike LP wouldn't go, Spiral wouldn't go, a 1.515 Takira wouldn't go. This is a balloon uncrossable lesion. So we actually use laser a lot as part of a wire across, gear won't go algorithm. We're increasing backup, adding a microcatheter, which I tried, are all things you do, and eventually we moved to laser. And so very simply here, we tend to use the smaller laser on more moderate settings, and you can see the laser passes very nicely through the lesion. With this after atherectomy, the laser, we had TIMI 3 flow, and with OCT guided stenting had an excellent final result. And so the main places we really use laser are for treating in-stent restenosis and for lesions where we can't get anything to pass. And so by summary, orbital and laser atherectomy and complex PCI, I think it's really critical that intravascular imaging should be used to guide complex PCI and calcium modification. Going back to Mamas's talk, we have worse outcomes with these patients and need to do everything possible to optimize their stenting. In our practice, we use laser mostly for ISR and for acute stent regret patients. We use it when the wire is across and gear won't go, and it does have some utility for debulking thrombus, although I didn't have time to show cases of that today. Orbital, classically, we tend to bias toward using it with large vessels that have calcium. It's really good for calcific nodules, and we will use it in in-stent restenosis, which is off-label to ablate stents and ablate calcium when laser fails. Thanks very much for the invitation to be part of this excellent conference. I appreciate it.
Thank you very much, Dr. Croce, for this excellent presentation. I think we have just 10 minutes for the discussion. And I would start by asking 3 questions to the panels. So do you have any preference in stent choice when doing a complex PCI? Any preference in imaging, IVUS versus OCT? And how long are you going to use dual antiplatelet therapy in complex cases? Probably I will start with Dr. An. Jung-Min, what do you generally do?
Yeah, thank you for nice questions. But for me, I don't have any preference for the stent selection. But I have preference for the imaging selection. I prefer the IVUS rather than the OCT because sometimes the OCT catheter is not easy to passing through the very severe calcified lesion. So IVUS is better than the OCT. So in addition, the IVUS is sometimes can visualize the better visual visualize better than OCT to see the vessel size, because vessel size is very important to make a good pre-modification and selection of balloon size. So I prefer the IVUS than the OCT, but I don't have any preferred stent selections. But I think the thin stent is better than thick stent to treat the calcified lesion and complex coronary artery lesion treatment, I think.
Any strategy for dual antiplatelet duration?
If it depends on the situation, but actually the long stent, the longer duration would be better. But if we do the IVUS guided stent optimization, we achieve the optimal stent result. I don't prescribe the dual antiplatelet therapy longer than 1 year. Usually 1 year, I think, enough. Sometimes the shorter.
What do you do? We cannot hear you.
Sorry.
Okay.
I agree with Dr. An, and in our practice, I always choose IVUS by the calcified lesion. Before we treat the calcified lesion, IVUS will tell you need to do rota or not, and after you do rota cutting, it will help you to decide whether it is a good time for implant a stent, and after stent implantation, IVUS will tell you whether the result is good. So for me, IVUS is the only choice.
And Dr. Flaherty?
Thank you. Our lab tends to use a lot of IVUS, but I think it really depends on local expertise and practice. I think they're complementary imaging platforms, and they each achieve the same thing. I think Dr. Kirtani pointed out a very important thing about modern day thin strut stents. They deliver better than they expand sometimes. So I think the speakers have focused on how important lesion preparation is, because stents will deliver but may not expand, and then you're stuck, as the case demonstrated. And I agree with Dr. An that 12 months of dual antiplatelet therapies are standard in complex cases, length of DAPT.
Thank you. So for Dr. Nakamura and Dr. Scheller, I have a different question. Do you have any experience with the shockwave balloon for treating coronary arteries? And if you have, can you please tell us which is your experience?
So we have only the 5 experience of the clinical trials. So I don't have not much, but so the ring calcium, maybe the shock wave is effective, but not the ring calcium is, I think, debulking device rotabrator OAS is better.
What about you, Dr. Scheller?
So I fully agree with all the speakers. Lesion preparation is the most important step when you have calcified vessels. In our practice, we usually start with coring cutting balloons, using non-compliant balloons, and then decide if we go ahead with rod ablation or in really selected cases with lithotripsy. Lithotripsy is an excellent tool according to our experience. However, you have to look at the cost of the procedure, and it is sometimes a bulky device, so you are not able to pass all the lesions. In some cases, you have to do a rod ablation before you can do other things. So that's the experience we have with it.
But is it, in your opinion, indicated when you have circumferential calcification, or you can use it even with nodular calcification?
You know, our experience is also limited because it's a new device. I think it gives you excellent results also in circumferential calcification. But again, you can reach this goal sometimes with the conventional tools, with non-compliant balloons, with rod ablation. And it's a matter of cost and reimbursement at the moment.
Okay, thank you. So do the panelists have any question for the speakers? So probably I have a question for Ajay. Ajay, once you put the synergy stent in the proximal lesion and it did not expand, why you did not use at that point laser atherectomy?
Yeah, so actually I had called for it, and the feeling was that with NC balloons I could sort of tack up the dissection and get a reasonable lumen and then potentially use it at that point. But I actually, what happened in that specific case is I went back with the IVUS and then the IVUS got stuck. So the idea here at this point was, try the NC balloons. If that doesn't work, then I would go to laser. I think in general, and I would agree exactly with what Bruno said in terms of the algorithm, NC balloons will often work. We don't have OPN balloon. That's another option, I guess, as well. But we tend to put laser, and especially laser with contrast, later down the algorithm because you can cavitate bubbles, you can get no reflow and all those things. We do it routinely because we also, like Kevin, have a referral practice like this, but we leave it further downstream. For me, I think we've actually used the peripheral shockwave balloon in cases not like this where it's that tortuous, but it seems to work effectively for these underexpanded stents. But because we don't have the coronary one, and also because of cost, I think it still would not necessarily move up as the first line therapy. I would still try with NC balloons first.
So I have one question to Ajay and Kevin. How do you select the balloon size for high pressure balloon size for lesion preparation? The small balloon would be safer, but would be less effective. So how to select the balloon size?
Yeah, I think for me, it depends on whether you're going to do intercurrent imaging before deciding to stent. You can be a little bit more measured with it. I mean, assuming you're doing atherectomy, if you atherectomize the vessel and then you're going to test it with a dilation to make sure it's compliant, typically take a proximal reference and a distal reference and average them to something that's 1-to-1. That's for a short lesion. If it's a longer lesion, obviously, it may take a couple different balloons because the vessel tapers, especially the LED. So, if you're going to image in between and you want to undersize a little bit, that's fine. But the times people get burned is when a 3.5 artery, they predilate with a 3.0, and the next thing is you see a stent with a waist. And at that point, you've lost the ability to make the case easy. And so we're pretty, vigilant about 1-to-1 sizing based on the imaging. And what the imaging shows us in many studies, if you don't know the size of the balloon based on the angiogram, we often get it wrong in that case. And so I think a fairly prescriptive, either IVUS or OCT guided strategy informs important decisions, like what size is my 1-to-1 balloon going to be?
Yeah, I just really quick statement in the Eclipse trial, which is a randomized trial of atherectomy versus conventional angioplasty, we prescribe 1-to-1 NC inflation of at least 18 atmospheres. So that's the generally imaging and 1-to-1 NC at reasonable pressure.
Okay, I think we are just in time. So thank you, everybody. Thank you to all the speakers and the panelists. So let's move to the other topic, which is diffuse long lesion and in-stent restenosis treatment. And the first speaker is Dr. Colombo. The title of his talk is Limiting Stent Length Back to the Spot Stenting. Dr. Colombo, please.
So I read the title, Treatment of Diffuse Disease, Physiology Guided Spot Stenting or No Stenting and Drug-Coated Balloons. A little bit more elaborated. I believe that is funny that I saw a few days ago there is a commercial DS of 2 mm diameter and longer than 40 mm. I would say, can you believe that? 2 mm DS, 40 mm long. Where do you want to put the stent? It looks like we came to the conclusion the stenting is the treatment of coronary atherosclerosis. Every irregularity, everything that looks funny needs a stent. I'm not so sure that this is the way to go. I have no conflict to disclose. I think it is time to put stenting and POBA with drug-coated balloon in their respective perspective. I know that in the United States you don't have drug-coated balloon, but very soon you will have it. Stent implantation should not be the default approach when treating a significant coronary stenosis. We have other tools. 40 years ago, Richard Schatz gave a lecture comparing stenting to veterinary medicine. Stenting was the default approach for any lesion, and killing the animal was the default approach for veterinarian 50 years ago. I think we came along differently now, and we have different treatment for different disease. We need to distinguish a malignant from a benign dissection. Not every dissection needs to be treated, and angiography is not always the best tool for decision making. And even imaging, seeing a flap does not mean that the flap will occlude the vessel. We need to go a little bit further in this process of decision making. When you see a focal stenosis like in the screen in a big vessel, 3.0, 3.5, 4, I think stenting is the default approach. So I'm not against stenting. As a matter of fact, I love stenting, and thanks God the stents are available. But when you see a diffuse disease like in the panel below, where it's difficult to spot where the area of significance is located, I believe implanting 2 or 3 long stents is not the best approach. And I would say not always, but consider DCB with FFR evaluation and maybe spot stenting or no stenting. But anyway, we need to move a little bit further. So large vessel and short stent, less than 20 millimeter in length or 30, 35. I just put 25, but don't be picky to the number. Evaluated with imaging as the default approach, no question. In other situations, such as long lesion with diffuse disease, what should we do? Use the same approach and implant long stent with imaging optimization. That's what we do now, and maybe this is the way to go. Or optimal lesion preparation with PDPA or evaluation and then treat with drug-coated balloon. The result may not be stent-like, but consider that the lower the gain, the lower the loss. If baseline FFR is 7.5, after lesion preparation is 85, and the follow-up is 82, despite a mediocre angiographic result, any problem? Are we looking at a perfect angiographic result or a physiologically acceptable angiographic result? I don't think this is contemporary interventional cardiology. Full metal jacket on the LED, occluded few years later, immediate result look very fine, and the stent look even reasonably expanded. And another metal jacket now is done on the circumflex with this type of complete stent expansion, and I'm not confident that this stent will stay open after 3 or 4 years. I claim a new approach. This is a case we did a few days ago doing gym. You see an LED lesion and the diffuse disease diagonal. This diagonal is 2.5, and I'm sure that if you implant a short stent proximally in the diagonal, you will need to implant a second stent more distally, or maybe to implant a very long stent. And a very long stent in a 2.5 millimeter vessel, I don't believe is a good approach. We did angioplasty and then used the dark-coated balloon. The PDPA was 89, and there was a dissection proximally, but the physiology was very acceptable, and we left alone. This is an anecdotal case. Patient did very well, not even troponin rise. But I think we need to collect prospective data and validate an approach to limit stenting when you don't really need them. This is another case, a diffuse disease LED with a severe proximal lesion. Of course, proximally, the 3.5 vessel, no reason not to stent. We pre-dilated, we did lithotripsy because the balloon did not expand. And then we implanted the stent proximally. I go quickly because this is standard. The cutting balloon, lithotripsy, non-compliant balloon. And then we implanted, despite a good result, but still in a 3.5 vessel, there is no reason to stay away from stenting. We implanted the 3.5, 24 millimeter DS, but distally, you see that there is dissections. We magnify here for you is it's not a good result. There is also an additional lesion more distally. So we dilated, we measure some pressure gradients, and you see the PDPA is 86, 84, the contrast FFR is 77. We did further dilatation just with balloons, and then we used drug-coated balloon, and then we repeated the physiology. The result angiographical looks much better, but there is still a proximal dissection. Nevertheless, the PDPA is now 94 proximally, 91, and the contrast FFR 87. So no need to place any stent. These lesions can be left alone. And this is the final result. Stent proximally on a large vessel and a DCB with simple angioplasty. Now you have a better way to evaluate these physiology. There is a monorail pressure system. I think there are two of them available on the market. One is a Navius. This is a new monorail inside LifeTech system, which is a very low profile, can be put on any wire, and can be used to evaluate IFR and FFR and PDPA. So very simple to make an evaluation of a dissection. This is an intermediate branch, long lesion in a large intermediate branch dilated with a balloon. PDPA, despite some small dissection, 92. Then we go with drug-coated balloon and don't implant a long stent. This is the final result, not a perfect angiographic result, but good enough to stay open. This is a right coronary artery, long lesion. We implanted the DS proximally, 3.5, but then we go with the drug-coated balloon. You don't need to do physiology all the time. If the result is angiographically nice, like here, a drug-coated balloon, not always a physiology evaluated or IVUS evaluated. I go quickly because these are just examples to show you the concept. Left main proximal LAD, no need to do anything else than implanting stents, IVUS guided in the best way, but in C, where you have diffuse disease, ideal for a drug-coated balloon. And if you have IVUS, you evaluate IVUS, but do not jump to stent any IVUS-looking dissection. Evaluate the residual lumen, evaluate the physiology before making the decision to cross over to stent. So stent proximally in the large area and drug-coated balloon more distally. This is a more extreme case, LAD diffuse disease with a very focal lesion at the diagonal. But look how tortuous is this LAD. It would be very difficult to implant a stent, not difficult technically, but difficult to assume that the stent in the distal LAD will stay open. We did a contrast QFR, which is all red, of course. There is a significant proximal disease diffuse distally. So we elected to do just balloon. We did balloon all over, even proximally. There is a dissection. By IVUS, you see a dissection, but nevertheless, the residual lumen is large. So the dissection is there, but if the residual lumen is large, the dissection will not occlude. And that's the reason why we decided to do drug-coated balloon. We don't even implanted the stent in the bifurcation because the result was so nice. And we did the QFR, which confirmed a good result, except the very red, very, very distal. And we have the 6 months angiographic result. Look, perfect remodeling on the right side with no single stent. And here is the other view, perfect remodeling with all the curves maintained. So I think we can skip this because it's the same concept. So just to finish, I would call on an approach to limit stent length. If the lesion is optimally pre-dilated with the goal to reach a good angiographic result, IVUS optimal but suggested. Following pre-dilatation, occlusion or a band dissection stent, optimal result with or without a dissection, pressure gradient, high call it less than 10, but needs to be validated. Yes, drug-coated balloon, no. Long stent or focal stent, is the focal stent evaluate again PDPA and should be less than 10. All pressure gradient should be evaluated for 5 minutes and be stable below 10 millimeter to qualify for DCB and focal stenting. Of course, if you're dealing with a large vessel over 3 millimeter, this approach can be put on a side and the stenting can be the default approach. Thank you for your attention.
Thank you very much, Dr. Colombo, for this brilliant presentation. So next speaker is Dr. Finn. Dr. Finn, the title of his presentation is Drug-Coated Balloon, Present Status and Future of the Technology. Dr. Finn, please.
Thanks a lot, Tullio, appreciate it. Great series of lectures, and always difficult to follow Dr. Colombo, very provocative. So I'm going to talk more generally about DCBs and what's to come. I think it's a very important new, for some of us in the United States at least, in the coronary realm, new technology that will be coming. For you in Europe and Asia, it's not quite as new. But what's important for a good DCB? Obviously, we need to get therapeutic drug levels. And that means we've got to have a transfer of drug efficiently within the time the balloon is inflated. And that drug level has to be maintained for weeks, at least 4 weeks, I would say, to have good inhibition of restenosis. We've got to have good healing, obviously, from the balloon components themselves. We don't want to have a long-term antiplatelet therapy. And I think that's one of the advantages of drug-coated balloons we haven't discussed today, but that may be a upcoming advantage. And also, of course, and most importantly, perhaps, because the drug is transferred quickly to the tissue, a lot of it can be lost downstream. And we do not want to have emboli of drug downstream where we don't want them. So these are the drug-coated balloons that have been approved for peripheral artery disease, or some of them still in trials. But as you see, most of them share a common feature, which is paclitaxel. Most of the time that paclitaxel is a crystalline form of paclitaxel. The doses vary from 2 to 3 micrograms per millimeter squared. As I said before, US, we really don't have a coronary DCB, although you guys do in Europe and Asia. And it's been shown for paclitaxel DCBs, they're much better for above the knee than below the knee. Below the knee trials for DCBs, for the most part, have failed or been marginal in terms of benefit, or sometimes lack of benefit and harm suggested. Whereas above the knee, really, it's been the standard for long lesions and very effective in a number of clinical trials I've outlined there. In addition, DCBs have taken over the realm of AVF stenosis. 2 clinical trials, one with the Medtronic Admiral paclitaxel DCB, the other with the Lutonix DCB. Both were published. There was more success perhaps with the Medtronic product, showing significant reduction in target lesion revascularization, whereas the Lutonix one was a little bit less successful. Again, the dose is much less for the Lutonix. And I think Robert's going to talk about this next. DCBs for ISR are certainly an important indication. And in this particular trial I'm showing you, which was published in 2020, DCB was better than DES for bare metal stent in-stent restenosis, but DES was better than DCB for in-stent restenosis. These were all paclitaxel DCBs as far as I know. Now, of course, we've had trouble with DCBs and a lot of trouble in the periphery with this publication of a meta-analysis by Katsanos 2018, basically showing that patients that received drug-coated devices, whether stents, paclitaxel drug-coated devices, whether stents or balloons, had increased all-cause death at 2 and 5 years. And this really set the field back in some ways and led to a lot of controversy about whether paclitaxel-coated DCBs or stents were safe to use for peripheral disease, or perhaps for any kind of disease. And there was a more recent publication in New England Journal of the Swede patent on randomized trial, which randomized subjects to either paclitaxel devices or PTA, and basically showed no safety signal. And the FDA did write the editorial of that paper saying they were comforted by the data, but not completely convinced, and said they were limited in scope. Of course, you all are familiar with the fact that DCBs, paclitaxel especially, lose a lot of drug into the body when they're delivered. The efficiency is very poor. About 10 to 20% of the drug actually makes the arterial wall. And you can see the concern remained the fact that a lot of that loaded paclitaxel perhaps was delivered to the body in places where we didn't want it, and that was the cause of the increased mortality. This continues to be a major controversy. So sirolimus DCBs are coming. They're in the future. And as we all know, it's the standard for coronary artery disease. It's on every DES, and it's been proven to be extremely safe and effective. Paclitaxel modifications required for DCBs, the crystalline form, means the coating integrity is really not great. It's variable, with a substantial portion lost downstream, and the loss of paclitaxel, as I said, remains a significant concern. We showed that in multiple papers now, showing downstream skeletal muscle emboli of paclitaxel, crystalline paclitaxel, as well as there's been some papers on coronary angioplasty showing decreased flow rates after angioplasty with paclitaxel-coated DCBs, showing you again concerns about distal emboli. And I think in the coronary realm, this cannot be underemphasized that paclitaxel, we do not want emboli going downstream into the myocardial bed. That's going to cause microinfarcts and worsening problems. So we have to be extremely careful in the coronary, especially space, with this technology. Now, sirolimus, of course, offers a lot of benefits. It has a much wider therapeutic range, safety margins much better. Of course, the problem with sirolimus is that it doesn't absorb as well, and its retention is poor compared to paclitaxel. Paclitaxel, when in the crystalline form, really forms a drug depot and can be released over time. And so the problem with sirolimus has been, how do we get it, first of all, to absorb into the tissue, and how do we extend its retention over time? Now, there have been two solutions I'm going to review today, although there are a few more on the market. The Magic Touch is one of those where actually these are phospholipid particles that encapsulate the sirolimus. That's put on a DCB, and it's transferred to the drug wall. And these phospholipid particles essentially house the sirolimus so that it delivers over time. And that's shown here in this experimental model. We did Raman spectroscopy and looked at encapsulated versus free sirolimus. You can see the amount of free sirolimus goes down significantly from 7 to 28 days, where there still remains a fair amount of encapsulated sirolimus at 28 days, showing you that sirolimus is released in a time-release mechanism over time. And that's shown here in the arterial wall PK level. This was done in a coronary artery. You can see that it's extremely important to demonstrate that sirolimus levels are therapeutic over time. And what I'm showing you is the curve for sirolimus over time in the porcine coronary model, showing you there are basically therapeutic levels or just slightly subtherapeutic up to 60 days, showing you why this product likely works. Now, this can also be done in an ISR model. The FDA really, for approval for preclinical, wants to see ISR models. It wants to see a model is essentially where we use pig coronary arteries, we implant a bare metal stent, we come back at 28 days and we treat that bare metal stent stenosis with a DCB. We then harvest at 28 days after that and look at downstream emboli, tissues, as well as the artery itself. And this was a study done with the Magic Touch system. We're really not looking at inhibition of restenosis because this is a low stenosis model. We're more looking at safety signals and whether there's any downstream emboli. And you can see there really was no concern here at 28 days in terms of the histopathology. The neoenema looks fairly well healed. There's no real inflammation or toxic effect. So really a good result. And you can see here there was really no difference in terms of needle area or stenosis, not concerning. It's a low injury model, but there was significantly more fibrin with the Magic Touch, which is a marker of successful drug delivery, than with the POBA for treatment of in-stent restenosis. So, and downstream findings in this particular study were extremely excellent. There were no real visual evidence of any downstream emboli. Very acceptable result, I think, in terms of safety. And this has been shown in clinical trials with this Magic Touch balloon. I'm not going to harp on this too long, but this was a 6-month follow-up registry, basically showing you that cardiac death, TLR, were all very acceptably low, showing you this product not only works, as I showed you in the animal models, but also in humans. There's also a solution sirolimus-coated balloon. This time it's a little bit different. Micro reservoirs house the sirolimus in a PLGA, basically a polymer. That polymer is transferred to the arterial wall with the help of this novel cell adherent membrane. This helps stick it to the arterial wall where it elutes over time. This is a similar model, except we used the de novo coronary model in the pig, and we didn't do an ISR model. We just looked at the effect of balloon injury on the pig coronary artery. Same idea, assess downstream myocardium. This time we had 4 groups: the excipient-coated, non-coated balloon, solution 1x dose, and 3x dose. And here you can see basically a similar result. There was very good morphometric result with increasing muscle cell loss as the dose was increased, which is a marker of drug effect, as well as other effects such as fibrin score went up as the dose was increased, showing you again successful drug delivery. And there were minimal, there was no downstream ischemic infarctions, and there were minimal detection of embolic material, especially with the 3x dosing, showing you very good result. This again was only been tried or in a peripheral model so far. You can see here that in this peripheral study that was done, it was a registry or one-arm trial for the solution for above the knee. You can see they looked at treatment 50 patients overall. Late loss was extremely acceptable to be in the 0.4, 0.3 range, basically averaging, I think 0.17. So extremely acceptable late loss results. And very comparable or better than paclitaxel in terms of restenosis. So probably another advantage of sirolimus, very effective at restenotic prevention. So the take-home messages are, I think the DCBs, as Dr. Colombo mentioned, are new technology. They're really here to stay. I think they're going to be used for a number of indications, ISR above the knee, AVF, et cetera. Concerns regarding the safety of paclitaxel DCBs remain, although they were somewhat allayed by the sweet pad. We cannot get around the fact that there's a lot of loss of paclitaxel into the body with a narrow therapeutic margin. I think sirolimus DCBs will emerge as a formidable competitor to both paclitaxel DCBs and DES for both de novo disease and ISR, but we need larger, more convincing trials. And because these sirolimus DCBs require a carrier, I didn't discuss this as much, they really have to be looked at long-term. We need to make sure the carrier itself does not pose significant toxicity. I think you'll see in the coming year, at least in the US and in Europe, I know ongoing, several new randomized trials of sirolimus DCBs are expected. So thank you very much for your attention.
Thank you, Aloke, for this very brilliant presentation. So the last speaker is Dr. Robert Byrne from Ireland. So the title of his presentation is Drug-Eluting Stent versus Drug-Eluting Balloon for instant restenosis PCI. What is the best weapon? So Robert, please.
So thanks very much, Tullio, for the introduction. Greetings from Dublin, Ireland. Thanks for the invitation to be involved in TCT Asia Pacific 2021 virtual and to talk on DES versus DEB for in-stent restenosis. What's the best weapon? So these are my disclosures. In the next 10 minutes, a couple of brief words of introduction, 1 or 2 sentences about the principles of drug-coated balloon therapy and ISR that I think are important, mention a general treatment approach for in-stent restenosis, because I think this is relevant for the question of do you choose DCB angioplasty or repeat stenting with DES at the end of the day. So we know, of course, that interventional cardiology really has been characterized by a series of iterative developments and improvements, and certainly drug-coated balloon therapy has represented a significant advance in the coronary with the initial positive data from Bruno's group in 2006 from randomized trials, and in peripheral we had data available from 2008 showing efficacy in terms of treating obstructive disease. Principles involved in drug-coated balloon therapy deserve brief consideration at the outset. The first principle, I think, is that meticulous attention to angioplasty technique is critical. We should remember that drug-coated balloons are really just a mechanism of delivering drug to the lesion at the end of the procedure. The pre-dil work needs to be done with other equipment, and also it's a fragile coating. It needs to be handled carefully on the table, and it needs to be brought to the lesion in an efficient time with a low dwell time. The second thing is the degree of lesion preparation is probably important. Even in a randomized trial, we were able to show in in-stent restenosis that if you systematically predilated with scoring or cutting balloons, that you got better efficacy from the drug-coated balloon than if you just did standard non-compliant balloon lesion preparation. So I think this is an important thing to remember with drug-coated balloon. The third issue to remember is, and we've heard about it already in some of the presentations today, that after drug-coated balloon angioplasty, we should be willing to accept results that aren't stent-like, because we know from experience that these vessels tend to heal nicely, and we get a long-term result, even if the result at the end of the procedure is suboptimal. Moving on then to look at a general treatment algorithm for in-stent restenosis, and there are a number of algorithms available. This is just one from a recent EAPCI consensus document. Essentially, there are two major steps we should think about. The first is the preparatory work, and I think the preparatory work is understanding what's going on. What's the mechanism of stent failure? Is it under expansion? Is it loss of mechanical integrity? Is it neointimal hyperplasia? And based on that, then to modify your lesion preparation, your pre-dilatation, either aggressive or conventional. And then the second step is to choose what you would call a destination therapy, which might be drug-coated balloon angioplasty, or it might be repeat stenting with DES. There'll be certain circumstances that clearly favor one approach. I'll call out just loss of mechanical integrity with stent fracture. That's an approach where you're going to want to put in an additional drug-eluting stent, and that's an approach where I don't think the randomized trial data will help us too much. So a role for individualized decision-making before we get into looking at the data in too much detail. So in terms of the randomized trials, there was 10 randomized trials comparing DCB angioplasty with repeat stenting with DES, and the Daedalus collaboration was one that we were fortunate to lead, led by a colleague of mine, Daniela Giacopo, where we were very lucky to write to all the PIs of the 10 randomized trials, and they all sent us their data. This has resulted in a couple of useful publications, which I think sheds a little bit more light on the relative efficacy of drug-coated balloon angioplasty and repeat stenting with DES above and beyond what you get from the individual trials. So two main papers to discuss, and here's the first one. This is the overall result. It puts the results of the 10 trials in context. You can see a nice geographic spread in these studies across Europe and Asia. The headline results are here on the right of the slide. Target lesion revascularization was the efficacy parameter of interest. Death MI, in light of some of the concerns that we heard already in Alok's presentation, was the safety parameter of interest. You can see here in terms of efficacy, there is improved efficacy with repeat stenting with DES. That's the yellow bars as compared to the blue bars, which represent drug-coated balloon angioplasty. If you look at the hazard ratio, there's about a 30% increase in TLR out at 3 years with drug-coated balloon angioplasty. But bear in mind, these are open label, and the operator, when the patient comes back, generally knows if the patient has multiple stent layers already or not in the case of drug-coated balloon. This may influence how keen they are to intervene again. You can also appreciate some overlap of the confidence intervals, but there's definitely improved efficacy with the repeat stenting approach. On the other hand, if you look at safety, you can see, well, if anything, there's a numeric trend in favor of the drug-coated balloon with higher rates of death MI with the stent-in-stent approach. It's not statistically significant. You can see that the confidence intervals are overlapping, but you're getting an appreciation of the trade-off that's involved between efficacy and safety. Now, one thing that we know is important from pathological work and from clinical studies is that there are important differences between restenosis after drug-eluting stents compared with restenosis after bare metal stents based on the pathophysiology of these two conditions. So in the next step with the Daedalus data set, we set about looking at this in a little bit more detail. And I apologize that there's a lot of information on this slide, but I'd like to take you through it just step by step. I think the first thing that you can see here is if you look at all treatments pooled together in the top part of the slide and just look at outcomes, what do you see? Well, you're seeing regardless of the treatment received, the patients with bare metal in-stent restenosis tended to do better. And this re-emphasizes that drug-eluting stent-in-stent restenosis tends to be more recalcitrant and tends to be more difficult to treat. On the next line, we look here at bare metal stent in-stent restenosis and drug-eluting stent-in-stent restenosis. And we look at the comparison for DCB versus DES. You can see here in terms of the treatment effects, broadly comparable when you're working in bare metal stent-in-stent restenosis in terms of efficacy in the upper part and safety in the lower part. And if you switch then and look at drug-eluting stent-in-stent restenosis, which is of course what we encounter more frequently nowadays, you'll see something that's a little bit different. And this indicates that there is evidence of interaction with the treatment effect effect depending on what the underlying in-stent restenosis was. And here you can see that it more clearly favors repeat stenting with DES if the underlying type of restenosis is drug-eluting stent restenosis. However, you can also see that the price to be paid is more marked because safety goes in a more marked manner in the other direction in favor of the drug-coated balloon and angioplasty, emphasizing, I think, again, the trade-off that has to be weighed in treating these patients. And finally, if you look at the bottom part of the slide, the final message from this analysis is if you look just at the patients who received drug-coated balloon angioplasty on the left and the patients who received repeat stenting on the right, you can appreciate a degree of treatment interaction for the drug-coated balloon angioplasty. It seemed to matter whether or not you had bare metal stent or DES in-stent restenosis, with differential efficacy in favor of the bare metal stent in-stent restenosis with the drug-coated balloon angioplasty patients. Whereas if you looked at the repeat stenting patients, you weren't seeing this divergence in efficacy in particular, and they seemed to be equally effective whether or not you were dealing with bare metal or drug-eluting stent in-stent restenosis. So I think we got a lot of information from the second step of the Daedalus analysis, and it really highlights the trade-off between risk and benefit. The recommendations in European guidelines at present are 1A for both drug-coated balloon angioplasty and repeat stenting with DES. So in terms of take-home messages, then DES versus DEB in patients with in-stent restenosis, both angioplasty with drug-coated balloon and repeat stenting with DES are important components of standard of care treatment. They're both recommended with an equally strong recommendation by clinical practice guidelines in Europe. It's important to consider a staged approach, understanding the principal modality of stent failure and employment of meticulous attention to lesion preparation is prerequisite to the choice of destination therapy, as I call it, with either drug-coated balloon or DES. And it's critical actually to the treatment success, regardless of the modality that you chose. The Daedalus data set is a very unique data set. It taught us a number of lessons. The efficacy advantage for repeat stenting over with DES over angioplasty with drug-coated balloon exists at midterm follow-up. It's modest, and it should be weighed up against the residual concern in terms of safety adverse events, which seem to be higher with stent in stent, particularly for drug-eluting stent in drug-eluting stent. We remember and we learn more data that there is lower efficacy and safety with either modality if it's drug-eluting stent instead of bare metal stent restenosis, because the former seems to be a more recalcitrant disease process. And there is interaction between treatment effect and type of restenosed stent, with greater efficacy advantage for repeat stenting with DES when you're dealing with DES restenosis. But remember, the jeopardy seemed to be increased as well in terms of the safety risk. So with that, I'll thank you for your attention.
Thank you very much, Robert, for this very comprehensive and brilliant presentation. Now we are open for the discussion. Are there any questions from the panel? So I probably start with Dr. Colombo. So Dr. Colombo, when the dissection is not occlusive or when the flow is still preserved, how do you decide when to leave the dissection? Do you need always IVUS to better understand the characteristic of the dissection, or angiography is enough for you to be confident that this is not a bad dissection?
As I said, angiography is not a good way to make the decision, except in extreme cases. Of course, we know there are some terrible dissections, and you don't need anything to evaluate that they are terrible. Nevertheless, there is a big group of intermediate, hazy results. And that's the reason why I think pressure gradients should be put back into the arena. It's not my contribution. Andreas Grunzig was the proponent of pressure gradients, but at that time, they did not have the tools to evaluate pressure gradient now as we have today. Now we have pressure wire, we have microcatheters, So there is no reason not to put back pressure gradients.
So I have one question to Antonio. So how to make a good angioplasty result? So to avoid the malignant dissection, what's your technical secret?
There's no way to avoid the dissections. Sometimes dissections is the only way you can dilate a lesion.
Yeah.
If you have to make a bottle larger, you have to break the glass. There's no way you can make a bottle larger without breaking the glass. So some dissections, just by luck, become benign. Some dissections are malignant, and that's the reason why you cannot do angioplasty unless you have stenting in your shelf.
So is there any plaque characteristic? Is there any plaque characteristic for the better for the angioplasty than stenting?
No, we should not be afraid to have a dissection only if we don't have stents available. I'm not trying to tell that stents should not be used. Stents should be used to treat malignant dissections, and dissection in small vessel should be evaluated because stenting a small vessel is not ideal. If it's a large vessel, 3.5, and you have a dissection, I wouldn't even spend time to do physiology. I will stent it, period. I mean, a 3.5 vessel with a stent of 15, what the hell to waste time? Place a stent. The long-term results are good if the stent is well placed. But if you have long diffuse disease, I will not place a 3 millimeter, 40 millimeter long stent. I will do something different. So, you know what I mean. I think you are. The problem is that new generation operators are not confident to do balloon angioplasty. For them, stent placement is the default therapy. If you do not place a stent, you have not done PCI. We should move away from this concept. PCI now is something more than just placing a stent. You can do good PCI without placing a stent. I give the patient a stent to take home in their pocket, not in their coronaries.
Thank you.
I have two questions for Dr. Colombo. The first question is, do you think the cutting, when you do the lesion preparation before using DCB, cutting balloon or scoring balloon is better than a regular balloon? The second question is, do you think it's necessary we must use intravascular imaging to decide whether we can use DCB or stenting?
Yeah, but you know, lesion preparation before. I think if you use if you don't plan to place a stent, maybe you have to do a little bit less aggressive lesion preparation. I'm still do not know exactly, but maybe you have to be less aggressive. But understand that to be less aggressive does not mean to do massage. You still have to inflate the balloon and expand the lesion. So this is a fine line. You know, I'm using this approach for the past 2 years, so I'm still learning. And I will really love if someone else does, so can give me some feedbacks. The imaging is important because imaging should also tell you how large is the residual lumen versus the lumen of the dissection. A dissection can be present, but if the residual lumen is very large, the dissection will not become occlusive. So do not just be concerned about the flap. You can have a flap, but if the residual lumen is large, the flap will not occlude. And this is something that we observe since many, many years. At the time of spot stenting, we didn't have pressure gradient. We just used IVUS, and we took the residual lumen as a key element to decide if to stent the flap or not.
A question for the speaker.
Robert and Alok, I probably have a question for you. Do we have any data from randomized trials or meta-analysis regarding drug-coated balloon versus drug-eluting stent in diffuse coronary artery disease, in small vessel or diffuse coronary artery disease outside in-stent restenosis?
Yeah, so I think, you know, it's an important issue. We do have data. We have some randomized trials. We've had some randomized trials from for a number of years, some done by investigators who are on this call today. The trials have mainly been modest in size, but they have tended to support a role for drug-coated balloon in de novo disease, with the proviso that it's in selected patients, and it tends to have been done by operators who have a lot of specific expertise in drug-coated balloon or stent-free angioplasty. So there is evidence. It looks encouraging from randomized trial data, but we lack very large scale trials for de novo disease. Nevertheless, the approach makes sense for the reasons that Antonio so eloquently describes. I wasn't doing angioplasty in the 90s, but I know from looking back that stents seem to have been adopted without the degree of randomized control trial evidence that you would have wanted in terms of systematic adoption. And there were a number of reasons behind this. There were also more limitations in terms of a balloon-only approach back then, because we didn't have drug-coated balloons. So if we were using balloon angioplasty, the risk of restenosis was higher, and probably dual antiplatelet therapy wasn't as mature as it is now. And I think those are maybe the two reasons which make it a more sensible approach now, even than back 25 years ago.
Thank you. So any other question? Last question from the panel?
I had a question for the speakers. What is your antiplatelet strategy after drug-coated balloon treatment?
I'll tell you mine. So we tend to be somewhat longer than other people on the call. We tend to be in, so first of all, obviously, if the clinical presentation is acute coronary syndrome, then the clinical presentation is acute coronary syndrome, and we tend to err more towards the side of 12 months. If you're dealing with stable disease, stent-free angioplasty, we tend to go for 3 to 6 months rather than, say, for example, 1 to 3 months, based a little bit on insights that we see from Aloki's team, showing this fibrin deposition if you get a good effective drug-coated balloon angioplasty as a marker of some degree of delayed arterial healing, not maybe as marked as we saw with first generation DES, but I'd say for reasons like that, we tend to go more for the 3 to 6 than the 1 to 3 months, unless of course it's a high bleeding risk patient, and that's the reason you're doing the drug-coated balloon angioplasty. Then certainly you'd be comfortable with a short duration DAPT like 1 month.
Dr. Colombo?
If I have a dissection and I don't place a stent, or I place a focal stent, I give ticagrelor or prasugrel in addition to aspirin for 15 days or 1 month, and then I switch to standard DAPT for 3 months or 6 months, whatever. But for the first 2 weeks, I give what I call strong DAPT. I just want to be safe. Maybe it's too much, but you know, I think I'm entering an uncharted land, so I just want to put safety number one. 15 days, it's okay.
Sorry I joined late. Quick question for Robert, and I hope he hasn't already covered it. But you seem to lump all DCBs together. Do you think the sirolimus DCBs are different than the paclitaxel DCBs in terms of efficacy and safety?
Yeah, I mean, it's a great question, and we touched on it really only in passing. We don't know really how they stack up against each other. We have a much larger general experience with sirolimus analogs, and I think we're all more comfortable working with sirolimus analogs than with paclitaxel if we had the choice. Alok in his presentation focused in a little bit on the problems with the formulation of paclitaxel that's required in drug-coated balloons, and he worried about downstream effects from paclitaxel in the peripheral bed. Now, I have to say, in the coronary field, I don't think we're that worried about it. We don't see an adverse mortality signal when we look at the randomized trials. And for example, in ICER-Desire 3A, which was a modest-sized randomized trial, we specifically looked in a post-hoc way at delta high-sensitivity troponin downstream as a surrogate for any downstream effects. And even using this sensitive marker, we couldn't detect any difference at all between plain balloon angioplasty, drug-eluting stenting, and drug-coated balloon. It seems, however, that any potential adverse effects downstream are going to be less with sirolimus, mainly due to the different formulations that are used in terms of nanotechnology, in terms of weeping balloons, in terms of excipients that are more biocompatible. And I think we're all looking for encouraging data with sirolimus-coated balloons because we'd be more comfortable using them in the coronary space. But we should acknowledge that while we don't have a great amount of data of large-scale trials with paclitaxel-coated balloons, it's a little bit too early to call on sirolimus-coated balloons at the moment, and there are a number of trials ongoing which will provide insight on it. But I'm hopeful.
Steve,
okay, this was your presentation. Any comment to that?
I would just add that the FDA is very concerned about downstream because of the paclitaxel issue that happened with the peripheral DCBs. It's going to be a big area of focus, and maybe Robert's correct, but you're not going to be able to see these downstream. These aren't major infarcts where you get, obvious slow flow. You may get some transient slow flow, but these are micro emboli. So it's not going to be easy to see these on an angiogram. So I think that is going to be something that's going to have to be really vetted very carefully before some of these products are approved, at least in the United States.
Okay, so thank you very much. I think this has been really an excellent and exciting session. I want to thank Dr. Ellis, the panelists, and all the speakers for their excellent presentation. Thank you very much.
Thanks. Thank you.